Hello to everybody who has just joined us. We're at about 110 participants, which is remarkable. You will see as you enter the room that there is a poll in process. So encourage you to take it, to look at the range of professionals that we have gathered here today. This poll will be closing soon. When the polls appear, please feel free to jump right in. These are designed to give you as participants and our panelists immediate information. So we ask that you take them right away before they will evaporate from the screen. At some point, I think we will begin to see here's the results that have come in. Lots of healthcare, some from the philanthropic community. I know we have at least one elected official on our panel, so that poll is a flawed one. Members, community advocates, of course, well-represented, educators, government employees. Few housekeeping areas before we begin. For those of you who are social media inclined, hashtag HCH community, we're using that, and Healthcare for the Homeless's Twitter handle is @HCHomeless. And we will be using these hashtags and this social media presence throughout the community of practice, which will not only be this two-part series happening now and 2 weeks from now in July, but throughout. This is a commitment organizationally that we have made. So why are we here? 8 months ago, in October of last year, it feels sometimes like 8 years, 150 leaders from a range of professional backgrounds. Many of the types of constituents represented on this poll today gathered at the Reginald F. Lewis Museum for a day of intentional conversation on issues of poverty and homelessness. And for those of you who were able to participate, you may remember a phrase that we used, and that phrase was critical discomfort. We wanted to have conversations of critical discomfort. At the end of that conversation, a 6-hour day, surfacing conversations among individuals and groups that do not historically work together. We asked ourselves the question, so what? What do we do now? And specifically, what is Healthcare for the Homeless going to do now? And so we ended 2019 and prepared to go into 2020 to answer that question. And then COVID-19 happened, and it transformed our organization, it transformed our community, it transformed our world. And yet, it is striking that a disease that first entered the United States among the relatively wealthy and affluent, to those who could travel and take cruises, had a disproportionate impact upon the poorest of the poor and the sickest of the sick, and those who could not isolate at home. We have known for 35 years at Healthcare for the Homeless that the majority of the individuals we are seeing, groups disproportionately represented among the homeless population, are Black and brown people. And we began to see both as an organization, that those that we were working with were not only more likely to acquire COVID-19, they were more likely to suffer adverse health consequences and even death because of it. And then the entire country, the entire world began to see that Black and brown people represented the large majority of COVID-related deaths. The entire world watched for 8 minutes and 46 seconds as a police officer knelt on the neck of George Floyd, killing him. The entire world again and again forced to reconcile with what already existed. Black and brown people being killed by police and white assailants at high rates. And these two things together, the existing health disparities so vividly portrayed through COVID-19, what we are seeing that was already existing with Black and brown people dying at higher rates, causes all of us to ask really the same questions that we were asking 8 months ago, but in decidedly different ways. We often talk about our home lives and our work lives as separate entities, right? Our personal selves and our professional selves. COVID's kind of destroyed that. We're all working from home, our home lives and our personal lives are integrated. Some of us more than others have had more luxury to separate our personal lives from our professional lives, particularly in the human services field. Something like what we are experiencing now, this intersection of these factors that we're talking about, I think causes great introspection in all of us, both as individuals and as organizations. How do we ourselves perpetuate racism, individual, structural, systemic? We ourselves as individuals, as organizations, as leaders of organizations. This community of practice is not meant to be an academic exercise, and it will not be. I would like now to introduce our panelists. We're very fortunate to be joined by a man who was with us 8 months ago at that community convening on homelessness, the Honorable Johnny Olszewski Jr., Baltimore County's executive. I am a proud constituent. And Dr. Lisa Cooper, director of the Johns Hopkins Center for Health Equity, the director of the Johns Hopkins Urban Health Institute, an epidemiologist, someone I was telling her before this session I have long admired on Twitter primarily and following her work. And the Reverend Dr. Todd Yeary, senior pastor of Douglas Memorial Church, also the vice president and the senior vice president and chief of global policy for the Rainbow Push Coalition, something that I did not know, but I had the opportunity to talk to you, Todd, about all of the incredible work that you are doing nationally and how you are traveling safely in the era of COVID. So I'm going to ask 3 questions throughout our session today. And each panelist will have 3 to 5 minutes to introduce themselves through the lens of this first question. And here's the question. Within your field, why is racism so uncomfortable to discuss, confront, and address? Let's think about that for a second. Within your field, why is racism so uncomfortable to discuss, confront, and address? So I'm going to ask that you share background information about yourself while you're answering that question. Before we start with the county executive, let's take a quick poll. Do you live or work in Baltimore County? 46% of respondents live or work in Baltimore County. So, Mr. County Executive, within your field, why is racism so uncomfortable to discuss, confront, and address?
Well, Kevin, first of all, thanks for having me join again. I think our first convening and those uncomfortable conversations were so critical that we had, and I really want to commend you and Healthcare for the Homeless for continuing these conversations, because we need to be having them, particularly in this moment, as you pointed out. It's a real honor and privilege to be doing this alongside Dr. Cooper and Reverend Yeary as well. So thank you for Baltimore County residents for showing up today. Those who live in the county may or may not know that our county covers about 700 square miles. We are home to 850,000 or so people. Those 700 miles cover a lot of territory. It covers everything from waterfront communities in the southeast, aging and industrial neighborhoods, newer suburban places like Owings Mills and White Marsh, older suburban communities, Towson, Catonsville, Pikesville, Reisterstown, and we stretch all the way north to the Pennsylvania line. Those 850,000 people are also pretty diverse, and we grow more diverse every year in Baltimore County. In the last census back in 2010, and if you haven't filled your census out, Baltimore County residents, please fill out your census. About 2/3 of our residents were white, about 1/4 were Black, 5% were of Asian descent, and 5% were Hispanic. My guess is that our upcoming census will show significant increases in particularly our Black and Hispanic populations, and a decline in the white population. But it's also important to remember that Baltimore County is an aging population. Fully 25% of our population is over the age of 65. In this government, we manage and develop a more than $3 billion budget. I lead a workforce of over 8,000 people. We deal with issues ranging from public health, although certainly that has taken on new meaning more recently, to public safety, to permits and inspections. We talk a lot about the school system, although we give half of our budget to the school system, but the superintendent actually reports to the Board of Education. And so, my field is government, but in some ways it's much bigger than that. It's about representative democracy. And so people have a reasonable expectation that elected officials are representing them. But in a county of 850,000 people, or thems, that expectation can oftentimes create conflict. And I think, what you see at, the recent situation at Vince's Crab House, in one of the locations or actually two are here in Baltimore County, is a good example. Some protesters outside have encouraged me to join them in protesting the awful, awful things that the son of the owner has written. The owners of those businesses and some of their customers are asking us to have us step in more, to do more to protect them. The property owner wants us to keep people off the property because of other businesses in the shopping center. And as county executive, I have a responsibility to all of those people, but also have a responsibility to call us towards not accepting the behavior that created the situation in the first place. So I think it just speaks to one element of how things like race and racism can be difficult to discuss, because it inherently means that we have to change the way that we're doing things. And sometimes that means that the way we allocate resources are different. And I think sometimes even if we don't change it, it can be scary. Our workforce, for example, here in the county is not very diverse, but our county is. That means we have to diversify our workforce. I can say that, and we all understand that, but how is that heard by the frontline employee who's been coming to work for 20 years and who's pretty proud of the work that they do? Rightly or wrongly, that frontline employee might have questions when I talk about the need, and having those conversations about what that means for them, for our county, for our community, matters. And that's not a reason not to have those conversations, because we have to have the conversations. But I think for me, it's about being intentional. And, personally, I grew up in Southeast Baltimore County. I did not have real conversations with a person who looked different than me until I started playing basketball. And that was in, Baltimore County 20 years ago. And so I think being intentional about that and having those conversations really forces us to move forward by examining our everyday practices, our systems, our policies. And I think that that's how we sort of get there together. I think I've probably exceeded my time already.
Well, I think I can say this as a county resident as well, but Baltimore County, one of the most segregated counties in the United States. And, you know, a question for you, and it's a question I've been asking myself in our own organization a lot, right? When I talk to one of our staff members, African-American male, who looks at me and says, Kevin, it took me a year before I could look you in the eye, because where I grew up, looking a white man of authority in the eye brought horrible consequences. What is it like for you as a white leader in this climate, considering everything that's been revealed? How are you personally wrestling with that?
I mean, it's making me take a look at my own privilege. It's making me think about what are the institutions that this county has been founded on? How have our neighborhoods been invested in? So it's caused me to reflect both personally, but also professionally about how we're engaging with this moment. You know, what's funny is, and I told this story on the campaign trail when I ran for this office, about how proud I was to be a first generation college student and to have grown up in a steel town, and you know, how, you know, what that those work ethic and what those opportunities meant. And I am proud of how hard I've worked to get where I am, but I also recognize that despite, even though I had fewer privileges than some, I also had many, many, many more privileges than others. And so just understanding that has been, I think, helpful and transformative as we sort of go about this work. And, you know, I already knew that we needed to do more about how we allocate our resources, more of the upstream investments, differentiating our resources in our classrooms, and providing more, you know, recreational opportunities for our kids, making sure that, you know, our new director of rec and parks, how all parks are for all people, and thinking about equity and how we have access to things like that. I mean, it really, you know, we had always said, and it's even in our strategic plan, that we wanted to put an equity lens to everything that we did. But even in just, you know, a few weeks listening, I mean, as a white leader, I think that I can't know the full measure of pain and frustration that so many others have felt, but I need to listen, and I need to be present and listen, because and just be part of those conversations so that we can act together and make some of the changes that are needed.
Let's turn to Dr. Lisa Cooper. Dr. Cooper, within your field, why is racism so uncomfortable to discuss, confront, and address?
Well, again, I just want to say thank you as well for having me today, and it's just an honor and a privilege to be here, having this really, really important and authentic conversation with all of you. I'm a physician. I'm trained in internal medicine, and so I'm primary care physician. I'm also a public health professional, so I wear a couple of different professional hats. So I want to tell you a little bit about that background, and then tell you why I think it's so difficult for us to talk about race. So as a physician, I actually did a lot of my training here in Baltimore, University of Maryland Medical System. So have been working in Baltimore for more than 25 years now. In public health, I went over to Johns Hopkins after I finished my clinical training at University of Maryland, and did training in public health after I realized that I was having a limited impact on the health of the patients I was seeing by only addressing them when I saw them in the doctor's office. So, you know, that's my professional background, but my professional background was heavily influenced by my personal background. I'm a first-generation immigrant from Liberia, you know, raised in an upper middle class family in a very, very poor country. So my father was a physician, and I was acutely aware from a very young age of how economic circumstances affected people's chances to live, you know, healthy lives. And so determined really from a young age that I wanted to work on this problem. And then when I came to the United States at the age of 17, I gained additional experience about what it's like to actually be a minority and to live as an African American, to live as a Black person in this country. And because Liberia was founded by slaves, and freed slaves that went back to Africa, I had a special sort of kinship with African Americans. And so really began to see how the situation that I saw in Africa with people struggling with financial issues and, you know, lack of opportunities for employment and education were not that different from some of the patients I saw right here in Baltimore, so that I could actually work to make a difference here. So now, why do I think race is so difficult to talk about? It's difficult to talk about wherever we live in the world. I can tell you that from all the places I've lived in the world. I've lived in Africa, I've lived in Europe before I came to the United States, and nobody wants to talk about race. But I think among physicians, one of the reasons it's particularly difficult is because we take an oath when we become physicians to do no harm to others and to treat everyone, you know, to treat humans fairly and to alleviate suffering. And so for us to think that that we are part of the problem, because you know, in reality, if we are going to talk about racism, we all have to look at ourselves and to see which part are we playing in contributing to this larger problem. To talk about racism would be to actually have to admit to ourselves as physicians that we might be actually contributing further to the problem by not treating people of different racial and ethnic backgrounds fairly, not giving them the same opportunities, not talking with them about certain topics the same way, not seeing them the same way as we see other patients. So I think that's one thing. It's really being able to really do that hard self-reflection. The other reason that it's difficult is I think it's like with other topics that we fear are painful to other people, we're afraid to open up wounds and actually be there and experience the pain that other people might be experiencing. You know, it can be very difficult. A lot of times we don't have the space or the time in the short periods of time that we have to connect with people for that. And then furthermore, we feel helpless many times because we know some of the problems are way much larger than what we can address in our short time with patients, and we don't really feel like we have tools. Many of us haven't experienced some of the same things our patients have experienced. Some of us have and can connect more easily on that, but others may not. And so when we feel helpless, you know, one of the things we do is to rely on things that we feel comfortable with. And so we write prescriptions for people and we order tests for them. And, you know, we try to avoid the topics that we know are going to be so hard that, or that we don't really have, you know, specific answers to. And unfortunately, that's not the way that we make progress, you know, in this. We have to learn that we, as a county executive just mentioned, we have to listen. We have to come alongside people and be present with them, even if we don't have a solution to it in the moment. But just to see people and acknowledge the situation that they're living with and the experiences they've had, and to tell them that they don't deserve that. And that's the first step. And then to begin to develop more of those concrete tools about how do we help them to address those barriers? How do we work as advocates in the systems that have perpetuated these inequities for years to make change?
Thank you, Dr. Cooper. And yes, I think that it is particularly prevalent in the helping professions to not look at ourselves enough, right? This, but we're the good guys. We're the good men and women. Instead of looking at the extent to which we ourselves are participating in systems. And now to Reverend Todd Yeary. In your profession, within your field, why is racism so uncomfortable to discuss, confront, and address?
Well, Kevin Lindemood, my friend, going all the way back to our first meeting in 2012 when I visited healthcare for the homeless as a member of the best leadership class, 2012. I want to make sure we get that on the record. Thank you for your commitment, your work, Healthcare for the Homelessness commitment, in modeling for us, I think, the best of affirming the human dignity of vulnerable populations and people. And to Johnny O and to Dr. Cooper, who we realize we have some connections, glad to be able to share this with you. Let's talk about why it's hard to discuss racism in my field, being a member of the clergy, community leader. Very often from our frame is that there are two things competing at the same time. One is this notion that racism in 2020 is now a fiction. It's a fiction because in 2008, we elected Barack Obama as president. And so we somehow moved into this mythical frame called post-racial society. Add that to the notion that the notion of the meritocracy, that when a few of us embrace and enjoy some level of success, that somehow presumes that there are not any lingering structural impediments to everybody being able to do what we do. If you made it, why can't others make it? The truth of the matter is if we look at Dr. Cooper, she's an exception to the rule. She's not the rule. There are more doctors of color who are foreign born that we're producing than there are who are born in this country. That we're still running into issues of access. When we start looking at the practical natures of cultural competency in healthcare, which we're running into in real time with the pandemic, we recognize that there are still some structural issues. The notion that somehow or other you could have a high achievement, but then be exempted from the suspicion that confronted Tamir Rice. Today, he would have turned 18 years old. We're still reminded about how quickly he was confronted by law enforcement playing with a toy gun, shows up on the 911 call, and in less than 2 seconds, he was dead. And so we have to remember that it doesn't matter how much achievement we have. I have had the great benefit of a family that sacrificed much for me to get where I am. So I am a Black man in America that is amongst probably the top 1% amongst education. I have a PhD and a JD. And yet if I walk out with what I have on today, jeans and a shirt with my hair looking more like my son's, if I end up in the wrong place at the wrong time, I'm still going to be followed by the suspicion of my very embodiment and presence. No one's going to ask about my resume. No one's going to look to see my business card. If I find myself in unfortunate circumstances, my label, which has been attached to me from my birth, born in a hospital in the colored wing in Augusta, Georgia in we'll just kind of put it out there, right? That the label sets certain parameters and expectations, certain opportunities, they're presumed. And so one is the fiction that somehow or other we're post-racial. George Floyd's killing, right? We would often call it a lynching. You had mob violence on camera. Shook us because now we have to confront what is often a big issue, white shame, not wanting to talk about it, and Black humiliation on the other hand. And so now, Rayshard Brooks, another issue. Tamir Rice was on video as well. We have to remember that. We go all the way back to Rodney King. It was on video. That time and time and time again, the humiliation of Black people has to be checked at the door as if somehow or other it's not going to be relevant or beneficial to any discussion about race. And so I have to hide my concern, my harm, my injury, because somehow or other I've been able to make it. And so when we deal with this notion of honest conversations about race, one, we have to recognize that racism is as real in 2020 as it was in 1619. The structures have changed. We have to recognize that the economic impediments, the disadvantages that are deeply embedded in the system are by design. They're not by accident. When we look at the recognition that, I appreciate Johnny O and his work in Baltimore County, but just the whole emergence of Baltimore County and what that looks like with the building of 83, right? The whole notion of white flight during the midst of moving Black bodies where the jobs were. White people moved to the suburbs, and then we started creating these distinct economic disadvantages favoring one community versus another. We have to be willing to talk about the history. And if we're going to have to enter the room in denial simply to accommodate the unwillingness to be uncomfortable, the conversation's supposed to be uncomfortable. Let me put that on the table. Why? Because we arrived here by the very things that ought make us cringe. Redlining started in Baltimore. It became kind of the pilot process for what we have now looked to when we look at the housing disparities. So when we realize that we have these different issues, the first thing that comes across when I talk to my colleagues is, one, will the conversation yield any benefit? Because the first thing very often when we have mixed race conversations is that we have to walk on eggshells, because if we talk too honestly about the pain of racial stigma, that somehow or other it's going to lead to otherwise well-meaning white colleagues to shut down and not really want to engage the uncomfortableness that is necessary if we're going to deal with the issues of race forthrightly.
Thank you, Dr. Ury. We have another poll that's coming up here. Have you known someone personally who was hospitalized or died as a result of COVID-19? All answers are anonymous, just to reiterate that. Wow, look at that. Look at that. More than 60%. Let's move on to our second question here. In order for us to move forward, and this is for you, Johnny O, in order for us to move forward, it's clear that we need to examine our everyday practices, systems, and policies. Can you tell us about what you are seeing in your analysis of racial inequities and disparities for distressed populations of color, especially those experiencing homelessness in the time of COVID-19?
Yeah, thanks, Kevin. And, you know, I just wanted to, before I jump into that, just further affirm what Reverend Ury was saying about the history and having those experiences. I mean, you have to, like, I'm also a former history teacher, and that really is so important to understand how we got there, and that you know, you can't change the future until we understand where we've been to get to this moment in time. And so and Kevin, you were such a big part of the fight to end housing discrimination here in Baltimore County, and just knowing what a fight that was and how that is but such a small piece of what needs to be done to unwind some of these longstanding practices, these institutional practices. There's also a lot to unpack in terms of the question. I mean, and I think sort of starting with those experiencing homelessness, I think you mentioned this already at the top, people who are experiencing homelessness, that population is at a much higher risk of COVID exposure than most others. And that has certainly created a challenge for us in county government. So we decided early on that we needed to go above and beyond, and we found hotel rooms for all of our homeless residents so that they could quarantine themselves throughout this process while getting those case management services that we provide. We had a relatively easy time doing that in Baltimore County, fortunately. Our colleagues in the city did not have an easy time. Apparently, they could not find a hotel within the city that was willing to rent rooms for that purpose. So the city ended up renting rooms on the west side of Baltimore County to house somewhere between 60 and 80 of their home, the population experiencing homelessness. You can imagine what happened next. First responders said that they were nervous about the hotel. Elected officials started asking questions. The community starts asking questions. Everyone was, becoming scared about a hotel full of a homeless population from the city and what that meant for them. People started describing that things were going to happen. Is there going to be an outbreak in our community nearby? But you know what actually happened next? Virtually nothing. Virtually nothing happened next. The city provided adequate case management. We did a couple of patient transports from the hotel to the hospital here in the county. but it wasn't the big deal that people in their mind created it to be. And you know, I share that to say that even when we are doing everything right, people still have this fear. And I think it's relevant both to your particular question, but also the larger conversation. I think we have to acknowledge that fear, but we also have to use it to hold ourselves to both a higher level of transparency, but also to challenge people on that fear. I think the more we can communicate about what we're doing and why we're doing it, the better off we'll be. But also, again, getting back to the Reverend's point about having those hard conversations and actually engaging in them. So we expect a long tail with COVID here. From a public health perspective, we also know moving forward, we can't return to the old shelter approach before. It's just not safe. So homeless services are high on the list on the things that we're reimagining in Baltimore County. Terry Hickey, who we actually stole from the city, but a real talent. He wears a lot of hats in Baltimore County now, but he's taken a hard look at what's possible, both in terms of providing shelter, but also in terms of how do we transition people into more stable housing situations. I mean, I'm optimistic about his work, but COVID has forced us to rethink a lot. It's an inflection moment. I think it's in part because of COVID, but it's also in part because of the murder of George Floyd. And so, you know, again, I mentioned in the last exchange about listening, you know, one of the hardest conversations I have had is a well-respected community leader in Baltimore County who lived through the assassination of Dr. King. She was active in the civil rights movement of the 60s. And she told me, she's like, Johnny, I can't believe that I'm living this again and that I'm still having these conversations. And she talked about the deep-seated racism in Baltimore County and beyond. And you know what? She's right. And so we've had a lot of conversations like that. They're not easy, but they're important. And so we're trying to take what we're seeing and in that analysis and move forward, whether it's, you know, implementing, and it's hard to believe it was a year ago, we had the county's first ever diversity and inclusion coordinator who's helping us do more work, but we're talking about a structured approach, creating the space for dialogue, but I'm not telling Troy to go figure it out, because I know as the leader of this government, I have to also be part of figuring it out and holding people accountable for the things that we're trying to do. So sorry that sort of went in a couple of places, but I think the lens of what those experiencing homelessness are meaning and what that sort of translates to is sort of a really timely question.
Thank you, thank you. Now I realize I'm asking this question of a physician and leading researcher on racial disparities in healthcare, but Lisa, in order for us to move forward, it is clear that we need to examine our everyday practices, our systems, our policies. Can you tell us about what you are seeing in your analysis of racial inequities and disparities for distressed populations of color, especially those experiencing homelessness in the time of COVID-19?
Sure. So, I mean, one of the things I've seen as a primary care physician is that we really need to do a much better job of enhancing access to care for everyone. So what I've seen is that, our populations that don't have primary care providers are really struggling in terms of being able to connect with someone that they can get help from, even if it's a question about whether or not they think they might have been exposed to COVID-19, whether they might need to go and get a test for it. A lot of our systems require people to have a primary care doctor to write a referral for them to even have a test. So if you don't have a regular doctor, you're already at a disadvantage in that you can't get a test. So I work at the call center at Johns Hopkins Hospital, so we get a lot of phone calls from people trying to figure out how they can get tested because they don't have a regular doctor that they can call. And so we have to figure out where they can go, and if they don't have a car to drive up to that testing center, we have to figure out whether there's a place where they could walk up or whether there's some sort of mobile testing unit that could come to their neighborhood. It's a much deeper struggle than for people who can definitely, who are already plugged into the system and already have coverage. I've talked to people who are immigrants, undocumented immigrants, who try to call like an information line, and there's no one who actually speaks the language that they speak, or they haven't gotten the instructions they need to get. I've seen people who are frontline workers who don't have paid sick leave. So, you know, they've gotten COVID-19 actually from work. Some of them are healthcare workers who have gotten infection from being at work. And now they're at home. They're sick. Some of them actually had to be put up in a hotel or somewhere else because they would have exposed their family members. And they don't have, they actually are worried that they're not going to be able to make their rent payments or the rest of their payments because they don't have paid sick leave. They're using up vacation time, and either that or they're not being paid at all during the time that they're sick with an infection that they got because they were doing the job they were doing, and now they have to stay home because, you know, they're being told they have to stay home so that they don't spread it to anyone else. Bus drivers I've seen. You know, so people who may even have insurance, but they're not paid enough money where they can afford the treatments they need right now. They don't have the internet service they need if they wanted to try to do a televisit with their provider. You know, people don't have enough cash to pay for their medications. The pharmacy's closed and they don't have a car, and who's going to go pick the medication up for them? So, you know, I see a lot of failures in our healthcare system and in our failure to provide basic insurance coverage for people. I also see that our healthcare system is not well connected with our social care system. So, you know, there are people who are calling, trying to get help with food assistance or with electricity bills, or they're trying to get unemployment or something like that. Can't reach them. And those of us in the healthcare system are not well connected, or we don't have the kinds of staff or the support systems or even the data collection systems that where we would be able to identify people who needed that help and then refer them appropriately. So I think there are lots of issues that have been brought to light by this crisis. They were already there, we knew about them, but they've magnified the problem. And it shows that since we haven't invested in these issues, you know, we are set up for actually the situation in which we find ourselves. And it would really behoove us to address these issues so that we are better prepared when this happens again, and that, you know, our people just deserve better.
Thank you, Dr. Cooper. Yes, we have seen access to telephone-only services so dramatically improve access to care, and we worry tremendously what's going to happen if that ends and it requires access to video services as well.
Exactly, because we know that's a time-limited thing. So fortunately, you know, people can do that, and the safety net providers can get reimbursed for that, but that's only for now. And then, you know, those systems, like the people that I work with at FQHCs, don't have the digital capacity, you know.
All right, let's turn now to you, Todd. In order for us to move forward, it's clear that we need to examine our everyday practices, systems, and policies. Can you tell us about what you are seeing and your analysis of racial inequities and disparities for distressed populations of color, especially those experiencing homelessness in the time of COVID-19?
Well, Kevin, that's an important question. There's so much that we have seen in these last several weeks, even as we are seeing the second spike. We were very concerned early on with some of the delayed response that if we did not move aggressively and address the issues of access, particularly amongst vulnerable populations, we were going to be at a significant risk, and here we are. Here's what we assume that practices that fit some are going to help most. So let's talk about the telemedicine question. We knew that was going to be an issue, right? Because the first priority list that came out was kind of tied to, do you have symptoms? And if you were asymptomatic, which has been a huge contributor to the spread that we've seen in high density, under-resourced communities, you were really kind of at a loss until you actually showed symptoms. Add to it, you still have underlying social determinants of health that further complicate it. So what do we find out? We start to see overrepresentation of Black people in not only the rates of infection, but in the death numbers, tied to the fact that there are comorbidities, underlying health conditions that have often gone undiagnosed as a part of that issue of social determinants of health, those health disparities. And so here were three of the key factors that were tied to complicating the ability to recover from coronavirus. One was obesity. Second was diabetes. Third was hypertension. And if we think about the other structural impediments, right? The obesity because of food insecurity, right? We have these food deserts that have persisted for so long, and access to healthy foods contributed to that issue. Add to it also the diabetes that goes with it, hypertension, the stress of having to deal and live in uncertain conditions, right? Those are all contributors. What we're seeing is we're moving, but we're moving much too slow. We're still waiting and hoping almost silently that some of the relief that might come just with the passing of time might relieve us of having to deal with those that we've stigmatized by their condition. And so now poverty is not just a condition, it's a crime. It filters your access. Let's just talk about it for a minute. If we needed to go to a drive-through test center, we talked about access. Well, if I don't have a car, I can't drive. And if there's no walk-up capacity and the distance is too far, and if I have to take public transportation that requires me to get on more than one bus, and oh, by the way, we restricted access to public transportation early on to essential employees and first responders, now I am trapped by my very insecurity, and I'm kind of locked into whatever might come. I mean, it's just one day to the next, will I make it long enough to be able to survive the transitions tied to this virus? And so we got to be, at some point, the credibility of a conversation around race, racism, the response in COVID-19 has to come with the fact that we can't keep passing half-hearted excuses for not doing the tough work in real time. At the end of the day, if the government, here's what we saw the government do in a matter of 2 months. They deployed $750 billion to support businesses, many of them gaming the system, small businesses getting left behind. So the argument that somehow or other we can't come up with the resources is a fiction. We should not embrace it anymore. Add to it the discussion about the HEROES Act. You talk about the other hat that I wear, it's on the policy side. The HEROES Act has to make states and localities whole. Well, what about states that did Medicaid expansion? And now there's some limitation on those dollars being available to help provide and support the care of the most vulnerable populations around the issues of poverty, which is also attached to homelessness. If we do not get our voices back, get the boldness about being able to speak unashamedly in real time. We're not running for office, so we don't have to get in. This is not for Johnny O. Johnny O's in, he's good. I don't have to be reelected, so I can say what I want to say when I want to say it. So I'm kind of liberated from that need to be liked. But here's what's happening is that there are actual lives that are being upended. People are dying in real time because we're not willing to deal with this issue of the system being skewed toward those who have, and it is still isolating those who have not. So we got to look at that. Where do we put these resources so that those who need the access, instead of having drive-through, let's drive to. I had a bookmobile when I couldn't get to the library. The bookmobile came to me. Let's take the testing and the treatment to the communities where the people are needed. Let's get the resources on the table, and then we can begin to address these structural issues dealing with the real-time issues of this virus.
Thank you, Dr. Uri. To say that we can't afford it is a morally bankrupt argument. Very, very much appreciate that analysis. Before we go to our third question here, we have another poll that we're going to launch. If you're employed, have you been encouraged by your employer to think and act differently at work in an effort to address racial inequities? Again, all answers are anonymous here. We've got almost everyone answering this question. about 73% say yes. And this will lead in very nicely to our third question. I invite all participants, if you have questions, after this third question, we'll move to some questions from those gathered here virtually today. Please direct those questions to the Q&A box at the bottom of your screen if you've not done so already, and we will be drawing questions from that box. So our third question for the county executive, through your professional lens, and this is, I really appreciate the professional lenses here. We have a county executive, a physician, and a minister and an activist. All I could spend time with each and every one of you on all three of these questions. That's far longer than the time that we've had available today. Through your professional lens, what should you and others in your field, what should you and others in your field be doing differently now to understand structural racism and racial inequities, exacerbated, though certainly not unique to, the time of COVID-19?
Where to start? Where to start?
In a couple minutes, right? Yes.
I mean, look, I think, you know, the exchange that you and Reverend Yuri were having at the end about, let's stop making excuses and let's start making differences in policy. Let's start making differences in our investments. Let's start making differences in the lives of people who are dying every day because of either our inaction, which is the easier thing, or our knowingly working against some of the things. And part of the challenge is, I think there are people who are working in these spaces. And, you know, for me personally, what it's done is it's sort of lighted a fire and a sense of urgency in a way that didn't exist before. You know, I sort of mentioned this earlier. When I came to government, I learned that we're disproportionately white and we're disproportionately male. So I tried to start changing that at the top when I built my leadership team. We hired the first ever African-American woman to serve as the county's administrative officer, the top appointed position in county government. It's, I guess, what the corporate world would call a COO. We brought a record number of women and people of color into the cabinet and other senior roles. But I know that that's just the first step, right? I mean, we have to be sustained and intentional about how do we change the enterprise, because the enterprise is the only way you're going to actually change what happens in the community. So, I mean, I think about this. The first time I saw the entire executive corps of the police department, there were literally no women at the rank of captain or higher. There were maybe 10% of that rank were people were men of color. The police department obviously is a hierarchical organization, and people come up through promotion. But you know, it was important and intentional that we hired the county's first ever female police chief. But it's going to take her time to diversify her leadership team. But that's why I've done things like directed her and our fire chief, also a woman, to make diversity a priority on the ground floor, the recruit classes. And I personally review them with the chiefs, and we're making a difference. Our incoming recruit class, for example, is 40% Black and brown, and then also if you count white women, we're over half of the class. So getting that moving is an important step, but again, it's only a first step. It's not enough, and so it's the reforms that we announced last Friday about the police department, about having officers having a duty to intervene if they see another officer doing what happened in Minneapolis. It's looking at our hiring practices from the outside and bringing in an expert. It's having our officers trained on things like implicit bias. And it's working with people like Troy Williams, and I did share via the chat, so if folks want to get a hold of him, both his name and his email. But he's leading that equitable policing work group. Troy is standing up both an internal and an external diversity council. He's rebooting our human relations commission. This goes back to having those hard but important conversations about where we have to go, how we got here, and then making the changes that are necessary, whether it's how we provide benefits, how we service, how we differentiate in our school buildings, how we provide counselors and school psychologists and pupil personnel workers and wraparound services. I mean, it all has to be part of the mix, but we can't just talk. I mean, I think these are all things that I campaigned on, but, you know, again, between COVID and the murder of George Floyd, I am so much more passionate about delivering on that promise. But I know that, you know, we got to get to the work. So.
Thank you. Thank you. Let's turn to you, Dr. Cooper. Through your professional lens, what should you and others in your field be doing differently now to address structural racism and racial inequities exacerbated in the time of COVID-19?
So I like to think about the things that I do as a physician and a public health professional in three categories: practice, research, and education and training. So in the area of practice, I think what we really have to begin to really not only just talk about, but actually do, is to better integrate the care of social needs into the delivery of healthcare. So by that, I mean, we need to have leadership that actually recognizes the importance of this issue, recognizes the connection between the legacy of racism and social and structural inequities and health, and can articulate that to others within the delivery system, to raise it as a priority, to recognize that comprehensive healthcare involves not only addressing medical needs, but also addressing the needs that people have outside of the healthcare system, identifying what those risks are, and better working in partnership with community-based organizations who can help to deliver that care. You know, so really creating the systems and using evidence-based practices to deliver that type of care, you know, in partnership with communities. So I think practice is the first area. I think in terms of research, I think there's much more research that needs to be done, not to document the fact that structural racism impacts health, because we have tons of evidence for that. And even in some cases, not even to like find out what works to address some of the issues, because we do know what works in some of those issues. And then what we need to do is actually find out why they're not being implemented. The things we know that work aren't being implemented because people have barriers to them. And so basically better understanding that, but also studying things like how we address implicit bias, you know, in healthcare delivery. Studying things like how do we get people to work better across systems and between healthcare systems and communities. Like, what are some of the attitudinal factors? What are some of the technical issues that are getting in the way? And then develop interventions to address them. In terms of education, we've got to bring a better education of the history of slavery and its legacy, and of redlining and all of these historical practices that have led to the structural inequities that we see now, so that people can better see the connections between these social factors and health, and stop creating this narrative, you know, that health is all about people, you know, changing their behaviors, because we know that people can't change their behaviors when they don't have the opportunities to do that. So I think public health students, as well as health professional students, need to really understand that history and how it's impacted where we are today, and what role they have to play in addressing those factors. And so some of the skill sets we can train people in are in better self-reflection about one's own role and one's own attitudes, a better understanding of the communities in which we live and work, better ways to communicate effectively, and then also maybe better ways to address the technical issues that we see related to things like housing and food insecurity, and you know, and job insecurity, you know, all of these other like issues that actually get in the way of people being able to make those healthier choices. So I think research, practice, and education, there's so much that we need to do. And I see people stepping up to the plate, but here's the other thing I want to make sure we caution against. I think diversity is very important, and diversity among leadership, but I want to caution us against using diversity as a way of checking a box. I think there's this way that we have of using that by basically picking a person of color or a woman or someone to represent that we are actually doing something, when I think we need to carefully choose the people we put in these leadership roles. They don't have to be only people of color or people who are representing an underrepresented community, although we'd like to sort of foster that leadership and support it. But I think they need to be people that actually have the values and the commitment and the skills to do the work, and not just are representing something that we can just check a box and say we did it.
Thank you, Dr. Cooper. And we look forward to involving you in the Housing is Healthcare movement as well. Very appreciate all of your remarks there. Turning now to Reverend Yeary. Third and final question. Through your professional lens, what should you and others in your field be doing differently now to address structural racism and racial inequities exacerbated in the time of COVID?
What we would do differently is be probably more intense and intentional about addressing it. These moments in time, these windows of opportunity open quickly and close even faster. We have the convergence of a number of simultaneous issues, not just in law enforcement and criminal justice reform. We're seeing disparities in compassionate release amongst vulnerable populations who have been incarcerated, and we know the disparities there. We could just go on and on and on about these touch points. I would suggest, though, that one of the things, to Dr. Cooper's point about knowing history, I would have all of my colleagues and anyone I talk to go back and read the Kerner Commission report. So in 1968, under similar circumstances where you had police encounters that had kind of triggered a number of urban responses largely, there were a number of underlying conditions, but the top line of the Kerner Commission assessment addressed forthrightly and upfront white racism. It called it out explicitly. We don't have to go back and feel like we're put upon to reach that conclusion. That conclusion has already been reached. If you change the reference to Black people in the Kerner Commission report, change it from Negroes to African American, change the city locations and update them, you basically have a current document. And so I would suggest that we go back and recognize that the same policy impediments that we faced 50 plus years ago, we're still facing 50 plus years later. The other thing is this dichotomous thinking, this either or, this argument that addressing the conditions of those who have been historically excluded and are most vulnerable requires us to answer this question of how we're going to pay for it. We're going to pay for it the same way you pay for the entitlement of the elites amongst us. That's never a question when we're trying to figure out tax cuts. It's never a question when we're trying to figure out how the top 1% controls so much of the nation's wealth. We don't have those issues when we're looking at the interest of those who claim real privilege. The other thing is that for most well-meaning whites who want to be friends, we want you to be allies, let's recognize the fact that if we're not going to deal with racism forthrightly, you're trapped by the same exclusion. Just because you have some limited privilege in some areas does not mean they're letting you into the real meeting where the pie is being not only just carved up, it's decided what the ingredients are going to be. And so we got to recognize that we've got to address this in a collaborative sort of way, and you're not going to lose anything. There's never been a time when there's been economic benefit for those who are most vulnerable, particularly around race, that did not benefit most of the folks who weren't really racially impacted. If we think about the social safety net, there are more white folks accessing it than there are people of color, and yet we often bear the brunt of having to explain why it is that we ought to be entitled to these basic investments in human dignity and human rights. And then finally, I would say for my peers, I wear a number of hats. If you have any responsibility for a corporate budget, for a government budget, remember the budget is more than the numbers. the budgets are more about the moral frame and the core values that inform it. And so if I want to know how serious you are and you have a budget attached to you, I'm going to look at where your dollars are being spent. And so I'm less concerned with the rhetoric. I'm more concerned with the work. And if we get to the work, if we get serious about avoiding this trap of feeling that somehow or other individually our white friends and allies are going to be put upon, you're not going to lose anything because whiteness isn't going away anytime soon. White privilege is not going to evaporate if we somehow become more concerned about racial justice. It is deeply embedded in the fabric. So you're not going to lose anything by giving folks a sense and an opportunity to be a part of the frame. And let's be serious about being more inclusive, more than just in our workshops. 2 hours is not going to make you a social justice ally. Going to your diversity training is not going to check the box, to Dr. Cooper's point. Until we change the structures and it's tied to the data and the outcomes, we're going to continue to have these issues. So read the Kerner report, get real serious about where you are, check your budgets, and let's stay at it until we begin to turn the dial and move the needle on where we are.
Thank you, Reverend Yeri. I want to be mindful of everyone's time, but I do want to take a couple of questions here with everyone's indulgence. The first here, I understand that over 50,000 people in Baltimore alone may face eviction when the moratorium is lifted. Moratorium on eviction, presumably, eviction or foreclosures or both, is lifted in a month. These will be mainly Black and brown people. This will result in so many more homeless, experiencing homelessness, and the health disparities that come with that. What will be done to lessen this horrific possibility?
Is that an open question?
I think that's an open question.
Yeah, I'm not probably the best person to speak to this, but I can tell you that as a physician and a public health advocate, I've been talking with a lot of policymakers about this very issue and urging them to consider like changing policies that will end the moratorium right away. Basically, to use funding, whether it's local or federal funding, to provide additional support for rent assistance, but also to landlords who may need additional support so that they can extend some of these generosities to their clients for a longer period of time. And I've been trying to make the strong case to our policymakers that not doing so will actually result in further pressures on the healthcare system that the healthcare system is not able to accommodate at this point in time, and that we're going to see more people getting sicker and we're in more danger of spread of the disease to everyone if we don't take care of some of our most vulnerable people, who are people that are housing insecure.
Anyone else? Todd, Johnny O?
Kevin, I would add, as the HEROES Act is still moving through Congress, I would suggest that you reach out to your members of Congress and make sure that there's sufficient funding to subsidize those who are still housing vulnerable, right? Because there are two things that are competing. Many of the multifamily units in some of our urban areas are owned by community-based organizations who are carrying a certain debt load, right? And so they're already under the pressure of possibly losing the properties, in addition to being put in the unfortunate position of having to decide how to balance the business responsibilities with the human responsibilities of keeping folks' housing secure. That should not be left to them. It should be taken care of in the HEROES Act. Create a set-aside that's going to allow, until we get to some level of stability, that there would be subsidizing of those who are most housing and most insecure in terms of their housing, and probably looking at where the income levels are, because the economy is not going to come back for workers as quickly as we would want. And let's figure out how to take that pressure off now, while the government is still trying to figure out who amongst their favorites is going to get some benefit of the national printing press.
Well, and as you're reaching out to members of Congress, make sure you also send something to Governor Hogan and tell him that we need eviction prevention supports here in Maryland from a state leadership level. What we're finding locally is that the challenges sort of roll down to us, and we have the least capacity in local government to respond. And I think Dr. Urey is right that Congress has the best opportunity through CARES dollars and through this HEROES Act to do something, but the state can do something too. And I've written a letter along with the mayor of Baltimore and the other major county executives asking Governor Hogan and calling on him to step up in this space. We put forward a little over $1 million in eviction prevention supports here in Baltimore County, and it was immediately oversubscribed. The need is incredible, and we're going to try to keep doing what we can locally. We put out supports for our small businesses with an emphasis on minority and women-owned businesses, and that fund is going to have, because people were left behind and those that they weren't favored and they weren't sort of supported through the CARES Act. Our local award is going to be well over half of our local business awards are going to be to WMBEs. So we're seeing the need locally, but we're not seeing the state or the federal government's really stepping forward and putting supports in places where we're going to do what we can, but we don't have anywhere near the resources as, say, a state of Maryland or our Congress.
Yep. And thank you, Mr. County Executive, for your leadership in eviction prevention. And we will ensure that we communicate out to everyone gathered today specific instructions for advocacy with the governor about needing to do his part now to stave off coming evictions. There are so many fantastic questions. I could spend all day here. I'll end with one final one. Is there a way to proactively address structural segregation in the Baltimore metro area? Proximity seems pivotal to addressing prejudice.
Kevin, I'm trying to get to the crux. Structural segregation seems to mean a lot. So one of my hats is I chair the Community Relations Commission for Baltimore City. We're starting to see, unfortunately, some indications that the proximity question, right? You don't call it what it really is. You kind of talk in code. Baltimore City is often used as, unfortunately, the excuse to use racial code for everything from how we deal with housing, how we deal with funding, how we deal with where folks live and why. And so we're starting to see just very recently flyers going around certain neighborhoods that are suggesting that somehow or other life would be better in the county, and that folks ought to consider moving to the county to get away from the issues of Baltimore City. And I want to make sure that when we start looking at these structural issues, the best way to, I think, to kind of deal with it is, one, we've not done, I think, a good enough job of looking at leveraging the power of regionalism in addressing some of these structures. Very often we kind of put the problems on individual jurisdictions to have to figure out on their own, without recognizing that there are just some things geographically about Baltimore City that aren't going to change, right? One is you're not going to pick it up and move it. So the port is still the port. The access is still the access. There's a need and a responsibility for us to make sure that Baltimore thrives along with the rest of the state. We're not going to be able to stigmatize the city and elevate the interest of the counties because they seem to be a better value, if you will, if we're not going to think more collaboratively around how government works for everybody. So I would suggest starting there.
Thank you. Thank you. Any thoughts from either you, Dr. Cooper, or you, Johnny O?
I'll just say that I welcome, the regional partnership. It's something that's been long overdue. It started recently under Mayor Young, and I've already had some really encouraging conversations with the Democratic nominee for mayor, at least, and the city council president. I'm hoping that we can continue that work. in any number of places. I think it's really critical.
Excellent. And Dr. Cooper?
Actually, I was trying to answer a question in the chat box that was directly addressed to me. So that's what I did because I felt like my two colleagues were doing such a great job answering the question at hand. So I will leave the responses to that to them. I was just entertaining a question from someone who is leading a safety net healthcare setting, and you know, they are sort of asking about how they can establish partnerships with healthcare delivery systems around addressing housing issues. And so I was just maybe suggesting working in partnership with insurers and also with community benefit programs in their local healthcare systems, which they do have to invest some of those dollars within their communities, and why not focus on the issue of housing?
Yes, yes. Well, thank you so very much to you, Dr. Lisa Cooper, to County Executive Johnny Olszewski, to the Reverend Dr. Todd Yeary. This has been a remarkable conversation. Let's launch our last poll. How hopeful are you about meaningful changes happening to address racial inequities in our region? We've got very hopeful, little hopeful, not hopeful. I think at this stage, being a little hopeful, it's pretty good. A little hopeful on addressing racial inequities, a little hopeful on ending homelessness. It suggests, of course, that we have so much more work to do. I want to thank each of you and all 140 some or perhaps more individuals who joined us today for leaning into this conversation today and entering into this space at the intersection of the personal and professional, and being willing to be personally uncomfortable. We need to get to further places there. I will note that in 2 weeks, we will gather back for the second part of this community of practice discussion. I'm very pleased to say that we will be joined by Howard County Executive Calvin Ball, by Randy Woods, the Senior Director of Community Care Coordination at a wonderful organization, Sisters Together and Reaching. Between now and then, what will you do? How can and will you apply a racial equity lens to your work, the work of your organization, to yourself? And I encourage us all to think concretely about that question. A survey will be sent immediately after this call, along with the invitation for that next discussion in 2 weeks, July 9th at 1:30, same time as it was today. Where do we go from here? Recovery stages of COVID-19. A participant list will be distributed to all participants. This is really fundamental to the concept of a community of practice. If you'd like to opt out, please notify us, but we very much hope you will not opt out and that everyone will opt in. But please notify communications@hchmd.org by the end of the day tomorrow, so that we can distribute a list in a timely manner. So only reply if you prefer to opt out. And so with that, again, thank you so much to Johnny Olszewski, Dr. Lisa Cooper, Reverend Dr. Todd Yeary, and to all of you who are at this point a little hopeful. That's a very good place to start. Thank you, and enjoy the rest of your Thursdays.